Hi, everybody. Welcome to our webinar today. I am Dr. Suen Wong, and I'm very pleased to welcome you to today's session on the concept of post-traumatic stress, the past, the present, the future. And for those of you who are longstanding attendees of our webinars, welcome back. You may remember me from hosting these events a couple of years ago. But for those of you who are new to EHN, we are a leading network nationwide of treatment facilities for addiction, trauma, and mental health. We offer inpatient services with centers coast to coast, as well as intensive outpatient and virtual options. For more information, you can visit our website at www.ehncanada.com. A couple of announcements to start off with for today's webinar. Everyone's camera and microphone are turned off, but please feel free to use the Q&A box at the top of your screen to submit your questions for our speakers today. We will also be sending out a follow-up email in the next week that will contain a link to today's recording, as well as your CEU certificate. Myself and Colette Currin are based in Toronto, which is located on the traditional territory of several nations, including the Mississauga of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat people. It is covered by Treaty 13 with the Mississauga of the Credit. Dr. Rakesh is located in Ottawa. The city acknowledges its location on the traditional and unceded territory of the Anishinaabe Algonquin Nation, whose presence reaches back to time immemorial. If you are new to this work and want to find out whose land you are on or grew up on, please visit www.nativeland.ca. I would also like to start off with an apology for the technical difficulties we experienced last time for this webinar, which resulted in the session being canceled. But I am very pleased that we've been able to reschedule for today so that you can still benefit from the expertise of our wonderful speakers. So without further ado, let me do some quick introductions and we'll get started. Dr. Rakesh Jetley is an internationally recognized thought leader in the areas of military and veterans mental health, suicide prevention, and post-traumatic stress disorder. In 2021, he retired as the Chief of Psychiatry for the Canadian Armed Forces, but he continues to be actively involved in cutting-edge research, having published over 130 peer-reviewed articles and book chapters so far, and chairs expert panels in areas such as morality of mental health, leveraging technology in mental health, and precision medicine. Dr. Jetley currently holds various advisory positions and, in addition, is the Chief Medical Officer of the Medicine Innovation Group, which oversees development and clinical trials involving psychedelics. We also have Colette Currin today, who is the Senior Director of Military Veterans and First Responders for EHN Canada. She is responsible for the business development of exclusive Guardian treatment facilities that offer highly specialized treatment and culturally competent client care, which includes ongoing transition management within these communities. Colette is a Canadian certified addiction counselor running inpatient, outpatient, aftercare, and family sessions within the EHN treatment network. Colette is currently completing her master's in counseling psychology and has just celebrated 30 years in her ongoing recovery journey. Welcome, Dr. Jetley, as well as Colette. And without further ado, I'll let you take it away.
Thanks very much for a great intro.
Yes, thank you so much. And well, Colonel retired Rakesh Jetley and I have worked very closely together for a number of years. And so really today, our job is to sit back and listen to a lot of his wisdom. I will be guiding him with some questions of our own, and any that you may have, please feel free to put those in the Q&A and I'll be sure to pass those on. But if it's okay, I'm just going to call you Rakesh because we know each other so well.
Absolutely.
Yeah, and maybe we talk a little bit starting with PTSD in the past and how this journey began.
Yeah, Colette, I mean, that's a great intro, and it's really great to be here. And I know we had some technical glitches, but we're still in the sort of the, close enough to Remembrance Day to kind of think about sort of the military and the intersection between science and PTSD. I think, when we talk about the past, I mean, and this is, I think the reason that we wanted to talk about this is because in sort of an Eastern philosophical way, like, let's not hang on to things too tightly because things change, right? And
Yeah.
if we read literature and history, if which I'm kind of a history geek sometimes with all the flying I used to do. But if you read about, the Carthaginian wars, with Rome versus Carthage and Hannibal, I mean, there are theories now that the carnage of that and seeing battlefields full of sort of dead soldiers on both sides may have been what inhibited, the final push of the Carthaginians. And maybe our history would have changed were it not for Hannibal just being overwhelmed by the carnage and the deaths, right? So we talk about that. Our near history begins with sort of World War One, right? For us in terms of our Western countries. And I mean, I know you're from South Africa, so for lots of us, it began with Australia, Canada, the Boer War as well. So
Yeah.
that kind of history. And what I'm going to do is I'm going to show a couple of video clips, and the reason that I'm going to show them is not necessarily to sort of necessarily this is PTSD, but this is the era, and we'll talk a little bit about them. But the first video, and they're very, very short, and just let me try to share my screen and just show them, and then we'll talk about them just a sort of split second after.
Mhm.
And I'll show this a second time because it kind of starts off pretty quick. So this is, when we think about it, more traditionally of what we think about PTSD, right? So you can imagine this is in French. It's from an old TV show from Dr. Louis Croc, who's one of our sort of founding people. But you can just see how, the person gets activated, during the discussion, perhaps having a flashback, suddenly goes under the bed and hides, right? So more and more traditional experience of perhaps the person is having re-experiencing a flashback and has trouble with the memory, whether it's in the past or not feeling safe, right? Just very much what it is. But this one now I'll show you a little bit different in the sense of we're talking about somatic response these days, the last wave, the last 10 or 15 years, we're talking about what's happening in the body. But let's take a look at this video briefly as well. So there's no physical injuries in these people, right? And after therapy and hot baths and some analysis, most of these people got better, right? But you can just see. And interestingly enough, this was found in Canadians and Americans, in the British, in the French, and in the German. So this wasn't sort of a culturally bound kind of expression. And so really, what we're talking about is, and this is, part of why I'm saying is that,
Mhm.
so at that time, Charles Myers, sort of the British physician that was practicing psychology, in the Lancet wrote about shell shock, right? And really it's sort of the manifestation. So you see cases like this, and you're thinking, okay, there's something neurological going on. There's something going on in the brain. So the theory at that time was all the shelling and the brain's shaking leads to this kind of manifestation in people. And so it kind of made sense. It fit the time, it fit the paradigm because people were in the, so really an organic basis for the illness, right? We think about mind,
Mhm.
brain. And he wrote about it in the Lancet. Later on, he predicted, he acknowledged the fact that other people were calling it shell shock. He's the first one that actually wrote about it. So that's the piece there. And around that same time, we had a lot of psychoanalytic theories. So, Freud talked about repressing bad memories, sort of pushing them down. And Genet spoke about just a few years before that about splitting off in this more dissociative kind of a way. And, dissociation has now made a comeback in PTSD. So the
Mhm.
idea of a
Mhm.
flashback being that split off experience suddenly starts permeating the memory, and the repression being a defense, and all of a sudden the memories start going up. So it's kind of interesting to visualize sort of the differences. And really, part of the issue in World War One, and there's some great literature and some studies from the Australians that talk about it. It was really thought of as being an acute thing. People will sort of get better over time, and the idea of this chronic illness was kind of new. But then when you looked at the claims that went to the different various veterans organizations or charities in our countries, every single year from World War One, the numbers start to increase for these so-called neurotic neuropsychiatric illnesses. And really, right up until World War II, the numbers kept going up. So this idea that you're having this acute sort of traumatic physical injury that has sort of, and when Myers wrote about it, loss of memory, vision, smell, and taste. I mean, there was different kinds of things, which again now sounds a bit like COVID as well, this medically unexplained physical
Right.
symptoms kind of
Ironically,
picture.
yeah.
It's just interesting how it comes back. And then again, with these wars in Afghanistan and Iraq, again, we're talking about IEDs and explosions and this mild traumatic brain injury combined with the PTSD and the fear and the shock. So I think it's really interesting. I think the part, and we'll talk a bit about World War II as well, because I think the part here that's important is the terms at that time were like neuroses, about repressed memories, about uncovering. And really the idea was that there's something within the person that has caused this. And depending on
Right.
the source that you believe, I mean, a guy like Myers was trying to legitimize and they talked about people being charged with cowardice and being hung and all this kind of idea. So these guys were kind of trying to say these people are sick. They're not just, poor moral fiber and some of those types of things. Um, we went from shell shock and then World War II. Initially they were called neuropsychiatric conditions or psychoneurotic conditions, and about 1942, the evacuation rate from Europe for neuropsychiatric was for the US was well over 100,000. I think it was about 142,000 people. And Omar Bradley, if people remember the famous sort of Patton films, Brad was his buddy, the other general, basically put a stop to it by starting to coin terms like battle fatigue. So the whole idea of battle fatigue, combat stress. So they're not sick, they're just tired. They just need a break, right? And so the idea of not labeling them sort of unfit, giving them this medical diagnosis, and I'm combining those two because one thing that gets forgotten, and we some of us are beaming into Ukraine right now, talking to some of our colleagues there, is World War I, World War II, the approaches taken weren't necessarily in the interest of people's health. The military doctors that are on here know that ultimately, the job is to conserve manpower, the job is to help win the war, right? Because it's not necessarily about the individual. So when we had the PIES principle, which was proximity, immediacy, expectancy, and simplicity itself, the idea there was bring people back from the front within the sound of battle. Don't make them into patients. Don't bring them to a hospital. Put them back within the lines, within the sound of battle, because they're going to go back. Give them a shower, give them some food, give them some fresh clothes, and then within a few days they'll go back. Right. So that was successful in getting people back. Was it necessarily successful for their long-term health? That's kind of the question, right? And
Yeah.
so I think it's really interesting to think about that. And to be honest with you, that's kind of the approach that we used in Afghanistan many years later. If some of the lads had some difficult days or a difficult week or two with lots of IEDs and stuff, the first approach was just to keep them inside the wire for a little bit, and then hopefully they'll get back, right? We didn't want to immediately send people back. Partly they wanted to stay in the fight, but also because we had a war to win. So
Right.
that's the
And
practical thing.
it strikes me as interesting what you're saying, Rakesh, because that video that you showed where that soldier was having a flashback experience, initially speaking to somebody who's trying to help him, this idea that let's keep them in the proximity of battle, so under the wire, within the wire, as you say. And is that ultimately better for them, while you have this kind of, we need to return you, to the thing that you came here for. I wonder, it's the exposure work that has to happen, and that clinician working with them. We have a question here that says, how do you support someone with PTSD when they transfer those negative thoughts or feelings with those who are trying to support them? So sometimes you're really kind of activating that intrusive response because you're kind of trying to work with them within their sort of existing sense of active combat. Any
Yeah.
thoughts on that? Yeah.
Well, I think when we look at what's happening in the world, with certainly within the Mideast, a place that I know very well, and Ukraine, I think one of the things that we have to think about is that post-traumatic stress disorder, like it's usually after it's after the trauma or it's after the traumatic stress, depending on whether it's post-traumatic. We've debated that for 30 years, but the idea is that it's after the event. And and the first element that you kind of impress upon people, you're safe now, you're home, you're not there anymore, right? So basically, we toss a lot of that out the window when we're talking to people that are being exposed to events that are being their ongoing trauma. I mean, so the guy inside the wire, yeah, you're going to go out and there's a chance that another IED attack is going to occur. There's another ambush that's going to occur, and so really, it's a matter of are you in the are you in the right frame of mind to go back to do your job? And the reality is that, again, as far as Canadian soldiers were concerned, when I was in Afghanistan in 06 and 07, they all wanted to go back. They all wanted. It wasn't about stigma. They really believed in what they were doing, and there's bad guys and good guys and all this stuff. So that's the one issue. It's in the ongoing trauma. It's not over.
Yeah.
The other aspect of it is that from a treatment perspective, the other aspect of it, when we think about Ukraine and you think about Israel and you think about all of this, is that we have to somehow scale what we know, right? There isn't going to be room for one-on-one psychotherapy with everybody, right? And so this is where technology comes in, and this is where, I know in Africa, one of the challenges that we had in Rwanda is that they share everything. They share the food you give them, they share. So we had a challenge because if you give somebody tablets for Shigella, they would give it to everybody in the family, right? So, but in a
Right.
way, we have to learn from that and give a small dose to everybody. So I think really, group-based things, peer-based things, mindfulness, helping people get sleep, helping people get rest, get the basic needs is probably the more important thing during an ongoing battle, right? During an ongoing battle. And really, we would just make sure that people are cognitively well when we return them to battle. And that's what had to happen in World War One, World War Two. Remember, in World War One, when we had surgeons, we had a few specialists, but most physicians of that era, I mean, let's say Boer War to World War One, were doctors of hygiene, right? Doctors of hygiene. We didn't have antibiotics, right? So it was really about where do we build latrines? Is the water safe? Is the food safe that we're eating? This kind of idea. Because the idea was to conserve people by keeping them healthy, as opposed to sort of treating the illness with antibiotics and medicines, because there wasn't outside of, and even surgery, because it was pre-antibiotics, the chance of dying from infection was very, very high. So I think, I mean, those are great questions. And what we have to think about is how do we scale what we know, and also changing our mindset to, you can't really call it post-traumatic. It's ongoing trauma. So it's ongoing traumatic stress. So how do we help people? And again, with the Canadian military, we've tried with our road to mental readiness and different kind of approaches to kind of help people to do things.
Yeah, I think that's a great distinction you make, as you say, when you're sort of treating, as per that video, the injury, while the stress it is post-stress, something has happened and the injury is there, but you're not kind of a month further down the line or years down the line, when now you're treating, the disorder. And that to me is very interesting. That's an important difference.
Yeah.
I have a question here as well about if you could talk a little to the links between substance use
Yeah.
and post-traumatic stress injury. And it was kind of couched in the context of that vulnerability that you spoke about, that initially people thought, oh, people coming in vulnerable if they've had ACEs, like
Yeah.
this person was mentioning there's an ACE score of 8 out of 10, for instance.
Yeah.
And perhaps a pre-existing overuse of substances. What's going on there between the two?
Well, no, I think those are great questions, and part of and then after we do this, I'll talk a little bit about the fear-based paradigm because I think it's connected a little bit. I think for those of us that work in this space, I mean, comorbidity is the rule. Right? Comorbidity is the rule, and I think that when we look at it, and 70% comorbid depression, probably and I remember some of the early studies with women's shelter for alcohol addiction. 70% of the women in that center met criteria for PTSD. Right. So that's this idea of this. So there are all kinds of theories. I mean, again, I mean, ACEs are common, 50% plus in military and veteran populations, a little about maybe 30 or 40 in the civilian. I mean, so ACE does predict suicidality. It predicts substance use to some extent, right? I think that I mean, it's a mixed bag, but I think the concept of self-medication is certainly there because at least the non-dissociative type, that sort of more traditional image of the soldier with PTSD is a highly activated person that has difficulty sleeping, that is difficult. So I think the self-medication, particularly in our in our culture where alcohol in of itself is kind of culturally accepted, if not encouraged at times, alcohol is so many of our patients would say, I need to have drinks just to quiet my mind, just to get to sleep. Dr. Bell, I mean, some of our colleagues might be at Bellwood right now, but Dr. Bell, of course, was a Canadian military doctor that one of the first after World War II to recognize the difficulty of transition coming back from war. And so his first clinics were based on treating alcohol, not treating PTSD, because people were coming back, isolating, withdrawing within themselves, and drinking a lot. So I think it's multifactorial. I think there are sort of generic risk factors. The last point, is opiates, and I think what happens is the U.S. went through a real lot of trouble with opiates. It's just starting to sort of get control of it in the last little while because a lot of times there's comorbid physical injuries, right? There's comorbid physical injuries, and the physical injuries, are chronic and they start to get difficult, and back pain, hip pain, and a lot of these, young men and women have been blown up, and so they have a legitimate physical injury, and then there's an empathy and maybe it starts off with an overprescribing of the opiates, but we tend to have, again, you've had burns, you've had injuries, you've had concussion, you've got pain, and you've got PTSD, and then the opiates kind of do help numb that. So I think it's a very complicated thing, and I think for those of us that work clinically, it's one of those things that you ask at the beginning, but you keep asking. Right? If people aren't getting better, you keep asking them about substances, and I think include marijuana, include alcohol, include all of them.
Yeah, and I like what you were saying, about Dr. Bell, and as you say, he himself having served in the military and being exposed to these conditions and coming back and starting a treatment center on his living room floor, dealing with shell shock, but obviously becoming Canada's foremost authority in his lifetime on addiction treatment, and also the first to introduce, cocaine addiction, sex addiction as inpatient offerings. Because of that, as you say, am I self-medicating to treat the hypervigilance and the hyperarousal and symptoms, and also avoidance, really, right? And so he saw that substitution happening, either with behavioral addictions or substances. But it's like, am I just sort of avoiding going out there and exposing myself? But sometimes I'm even avoiding the internal climate of memory.
So it's an active avoidance, absolutely.
Yeah.
So when we go then, like, so World War II, so up until that time, World War I, World War II, all of these things were based on a person's inner vulnerability, neuroses, neurotic
Yeah.
reactions, all of these things. And that was the kind of language. But it was really DSM-3 in 1980 that created PTSD, right? And
Mhm,
really, if you
mhm,
read the literature from that time, it was really to explain this mass group of young men mostly that were coming back from Vietnam, right? They were coming back, they were addicted, they were misbehaving, they were having trouble, and we'll talk about maybe moral injury, all this kind of stuff, because it wasn't a popular war, right? So society
mhm.
didn't welcome them back the way they were welcomed back from World War I and World War II, with baskets of wine and hugs and things as the trains came back.
Yeah.
So the U.S. had a decision to make, really. I mean, do we build a whole bunch of jails for these people and segregate them, or do we build VA hospitals? And they chose, thankfully, the latter. And then diagnostically, we didn't have a diagnosis. And so a lot of them were being diagnosed as schizophrenic because, you're
Mhm.
behaving weird, you're suspicious, you're isolating, you're having these unusual, the flashbacks could look like psychosis, right? You're hearing things, you're seeing things that aren't there. So a lot of them, met that criteria. So they created for DSM-3, they created the PTSD diagnosis. And what's really, really important about it, though, is that and again, it made sense at the time, the fear-based paradigm. We'll talk about that, but it was the first time acknowledging an external cause of an illness, right? So the
Mhm.
first time giving it, of course, there's an inner vulnerability to it, but it necessarily required the outside force. Now, of course, intoxication, there's a few substances. I mean, you can talk about that. But the theory behind the illness for the first time was something occurs from the outside that overwhelms you, right? Which is
Mhm.
which is which is very different from the neurotic, the inner thing within you kind of exposes this. So I think that was really important. Now the fear-based paradigm has fallen out of order a little bit. It's all we had at the time, and that's why we had, PTSD. That's why we had PTSD as the within the section in DSM of fear, because I think as we continued to work, we kind of started to question, is a fear of men after being raped the same as the phobic avoidance of a spider or heights, right?
Mhm.
Is continuing to relive the death and destruction that I was exposed to, is that the same as a phobic avoidance, right? And then I think over time we kind of said no, and it fit a lot of our theories. It fit the cortisol. It fit and there are some people that respond to the traditional therapies, and I think the fear-based paradigm has its limits, and because we were so entrenched in that, in the CBT world, all of the evidence-based treatments, the first wave of therapies were exposure, desensitization, habituation,
Mhm.
which
Mhm.
work sometimes and work about half the time if we're lucky, very high dropouts, but there was something missing, right? So
Mhm.
I think when we look at sort of, when we looked at the old brain studies, and we found the
Mhm.
hippocampus was big, the memory center, the amygdala was running amok. Everything kind of fit into this fear-based thing.
Mhm. Mhm.
And what happened was, and this is where I sort of took issue with it, we had animal models of PTSD where we took a rat and electrocuted its feet. And I remember challenging the scientists, saying, that's not an animal model of PTSD, that's an animal model of fear, right?
Right.
Yeah, you're
Right.
scared, you're scaring the shit out of the animal, and it's reacting because it's scared, right? So what about the
Mhm.
meaning? What about these things? So
Mhm.
I think that's part of what we need to think about. And
Mhm.
as we're learning more and more as we evolve, is that the fear-based paradigm makes sense for some typical single episode motor vehicle
Mhm.
accident. I can't drive anymore, I'm scared, I'm jumpy when I get in the car, it's really hard to be a passenger. Then yeah,
Mhm.
desens,
Mhm.
habituate, whatever.
Mhm.
But I'm dirty, I don't deserve this, I it was my fault that I got
Mhm.
raped. It was this. I mean, that's a little different than a phobia, right?
Mm.
If we listen to our patients. So I think
That assimilation, yeah.
yeah,
I do want to talk a little bit about treatment. And of course, I have the inevitable questions about the MAPS trials and MDMA and so on. So I'd like to go there as well. But as you say, really what has been traditionally used in terms of gold standard evidence-based practice is the cognitive therapies and understanding how I've tried to make meaning out of
yeah,
something really traumatizing. And so those approaches of can I help to get some of that unstuck? And
yeah,
we've also seen that the efficacy with that has not been, all that amazing. I mean, there's been sort of symptom improvement, but not all that amazing. So maybe if you could tell us a little about treatment and the ones we hold on to, the
yeah,
CPTs, prolonged exposure,
yeah.
EMDR, and what we're moving toward.
Yeah, no, I'll
Yeah.
talk about that, and so what we'll
Mm.
talk about is how we've moved away from the fear-based paradigm and what we've done.
Yes.
I think it's really important.
Mhm.
So we had over the last 100 years, I mean, and many people disagree with it, but we have these false dichotomies, right? We have this, I mean, Ruth Lanius often talks about, cogito ergo sum, I think therefore I am is
Yeah.
wrong, right? I feel
Right.
therefore I am is probably more appropriate, but we've got this mind-brain split as if
Mhm.
somehow there's this spiritual imaginary thing called the mind, and then there's this brain that's a separate organic thing. So we put that together. Then we also have this split, and I remember, when I was a general duty medical officer in the military, like there's, above the neck, below the neck kind of idea, right?
Yeah.
And so PTSD is a whole body disease, right? We and
Yeah.
and we know about that. And I remember, at that very same conference, where there were, for some reason there were 5 talks on the animal model of fear, as I call it. There was also a fascinating picture of zebra and different animals at a watering hole in Africa, right? A photographer took some pictures. And what was interesting was that every animal had a scar on their hind, and they had been wounded, and they had so the ones that so when you
Mhm.
think about threat and threat response, running away, this kind of a thing, it's not so much this fight flight and just taking off and escaping the lion. It's actually you've been wounded and you've survived, right? So
Mhm.
to me it
Mhm.
made me think about, so trauma, the mind, when you're being threatened, the mind is being prepared to wound you, right? You're being prepared to be wounded, whether it's a
Mhm.
psychological or physical threat. You have that fear. So the cascade inside your body of your inflammatory markers, your clotting markers. We've got the evidence now that shows that all starts going. So you're actually the inflammation in your body. So it's not just about cortisol. It's about, all the other things. There's adrenaline, there's cortisol, but there's interleukins, all of these things. So you're being prepared to be wounded. The little baby that's being, like the little girl that's being sexually abused is prepared to be wounded. So your body has this cascade of all of these things. And that's where, so what we realized was over the years, and we kept looking at the data and we kept dismissing it, but the idea of premature death in veterans, right? And many times it was, attributed to lifestyle and smoking and drinking and drugging and all this stuff. When you control for those things, you still
Mhm.
find an
Mhm.
increased rate of, diabetes, arthritis, chronic pain, heart disease. Heart disease is about inflammation of the endothelial lining. It's not about squeezing of the vessels. So what we have to start to think about with treatment is we have to think about not just the brain mind, we have to think about the whole body, settling the whole body.
Mhm.
And
Mhm.
so the new wave of the therapies, whether it's, I mean, EMDR started with a little bit of this stuff because it's exposure, but paying attention to what's happening in the body, accelerated resolution therapy that's become popular in various networks.
Mhm.
There's
Mhm.
brain reorienting. There's all of these. There's the Hakomi, the touch, the body movement, and the whole, even 3MDR, which is again something that we've brought into Canada from the Netherlands with Ottawa, and in Alberta we're doing some trials. Even that has caused the idea of getting people moving, not just staying
Mhm.
in their heads the whole time. And then we look at the benefit of exercise, the benefit of yoga, the benefit of all of these different types of things. So I think body based
Okay.
treatments with, of course, some mind based treatments, I think
Mhm.
are important. I think the valence of moral injury, like I think the again, good cognitive behavioral therapy, and our colleagues that are experts in it, it's
Yeah.
not a technical thing. You're still talking to your patients. You're still trying to get, not just sort of taking them through the process, but the idea of sort of listening to where people are with their guilt, their shame, their anger,
Yes.
processing some of those things, I think is really important to sort of listen to people, listen to
Sure.
where they are, because
Mm.
what tends to happen is the the sexy legitimizing trauma. I was on this road, our vehicle got blown up, two of my buddies died. I mean, that
Mm.
gets you in the door.
Mm.
But what really may be paining them is seeing the little kids on the side of the road
Mm.
that had no food or had no shoes compared to their own kids, right? So
Mhm.
so the thing is, the noisy thing that gets people in. So then I can expose you to death over this accident, and you can
Mhm.
start to sort of
Mhm.
not do it. But then you need to check in on people, and when they're not getting better in particular, and say, have I missed something? Because sometimes, the big explosion is the ticket in the door for the PTSD as
Mm.
far as
Mm.
Veterans
Mm.
Affairs and everybody is concerned. But it might be the next day when they went into the civilian hospital and they saw, no incubators. They saw things like that could be
Sure.
bothering them. So I
Sure.
think, and I think that when we look at sort of like a phobia to a spider, desensitization, habituation, virtual reality spiders, all of that makes sense, right? Show it
Mhm.
to you again and again and again. You're going to desensitize, you're going to habituate,
Sure.
and it's not going to be as scary. I think that makes sense, but we don't
Mhm.
need to necessarily explore the meaning behind the spider,
Sure.
right?
Sure.
And also the whole body expense, the pain, which is again what leads to sometimes the addictive behaviors and those kind of things. We don't address those. So I think it's really important to look at that. I think that our good friend Sandy McFarlane from Australia and Eric Remetten from the Netherlands, and there's been some great publications lately on just maybe we should look at PTSD like cancer and have a staged approach to it, depending on
Sure.
how many
Sure.
body systems it's affecting, and our treatment could kind of
Mhm.
follow that. So I think that's really encouraging.
Yeah. Yeah.
Sandy, of course, will point out that the medications we use, like the SSRIs, at a
Mhm.
high enough dose, guess what? They're actually anti-inflammatory. So they actually do settle down some of that inflammation in the body, and maybe that's kind of part of how we're helping people. But if you
Mm.
exercise, sleep is anti-inflammatory, certain dietary things, yoga, all of these things settle down those kind of, those biomarkers that we think are going to
Right.
contribute.
Right. Like, can we do that the old-fashioned way in a very
Absolutely.
holistic,
Absolutely.
self-agency
Yeah.
propelled
100%.
attempt at a solution? Yeah. There are certainly questions about any changes, changed approaches in medications, and of course that starts to take us into that area
Yeah.
of MDMA trials and
Well,
psychedelics and
yeah,
so on.
yeah.
Yeah.
No, I
Yeah.
think it does. I mean, I think it does. I think there's a
Mhm.
very interesting thing, and I think people like, Ruth Lanius just down the road from all of us, that whole dissociative
Mhm.
subtype kind of brought up this up to 30% of people have the zoning out staring. So I think it
Mhm.
starts with a very careful diagnosis. I think medication treatment continues to be symptom based, right? I mean, there's
Sure.
a couple of meds, like sertraline and paroxetine have the indication for PTSD, but all the SSRIs are being used. And I think that,
Mm.
we often use sleeping medication, which again, ideally you'd want a more holistic, you'd want, like cognitive behavioral therapy for insomnia, sleep hygiene, all of these things. But at the end of the day, sleep is the number one complaint that people with PTSD have, regardless of the cause, regardless of rape, motor vehicle accident, combat. Sleep is the biggest issue. And if they can't sleep, they can't do therapy. If they can't do therapy, they won't do their homework. I mean, so I think it's
Mhm.
crucial. But I
Yeah.
think the idea of medication targeting the symptoms, right?
Mm.
Depression. In theater, we used a lot of beta blockers because the soldiers were shaking. They were so sort of afraid and things. So I put them on beta blockers because that it would be stigmatizing to walk around shaking and not being able to eat. So it really
Mm.
has been that. Now I'll tell you that on the horizon, the pharmaceutical industry has very, very much sort of abandoned us over the years. But Boehringer Ingelheim, which is one of the big private you know
Mhm.
gazillion
Pharma.
dollar, billion dollar pharma companies, has just developed a molecule for PTSD, right? And they're about to start phase 3 trials, and I'm hoping they will do some in Canada. I've been talking to them, and it's a drug that's specifically targeting the amygdala, right? It's specifically targeting the amygdala, to quiet down the center of the brain that kind of drives. Now we know it's not as simple as that, and we know there's other neural networks involved. So maybe it'll quiet the noise, right? Maybe it'll quiet the noise to allow the therapy to take place, kind of like the stellate ganglion block. And we've got some data in some of our studies where EEG-based neurofeedback, even one session, quiets the amygdala. So I think the idea of the old, so that's a drug that's coming. I think in the future we maybe have the the MDMA, the psilocybins. Again, they're different medications. MDMA, it's more creates empathy and sort of like loving connections, and I think in PTSD probably creates that for yourself, right? That's not just between you and the therapist, but it creates that thing. So the results of the phase 3 trials that were published in Nature in May of this year were outstanding. I mean, like, and it's very intensive psychotherapy. 2 people giving psychotherapy for 8 hours at a time, 3 times, and that's 67% of people no longer met criteria for PTSD, and over 80% of people had significant improvement, right? And that lasted several months out. So I think that's exciting. I think that what psilocybin is a completely different thing, a true psychedelic, may change the brain, and allow new learning to take place. So it may actually have that as well, right? So I think as we look at these, the Senate report came out last week, the Senate subcommittee on PTSD, and very responsibly advocated for more research, right? I think we need to demonstrate the safety and efficacy, who it's going to work for, who it's not going to work for, any kind of adverse effects. So I think that's the piece. And I know there's some folks in Toronto that are going to do, 1 dose of psilocybin followed by CPT, right? Because when you look at the brain studies, the psychedelics may increase learning for a short period of time. So we have some pretty exciting stuff coming down, and I think the more and more psychotherapies that are coming, and looking at that, I think we're in good shape for the future.
Yeah, and it's when you talk about that therapeutic alliance and the good old-fashioned conversation, I think it does talk about this area of shame and guilt, and so many people commenting on that idea of sort of, yes, I've signed up to do this, but it's an injury, and so I'm so devoted to this life of service, but there is an injury to my moral values, and it's possible to have dissonance between two things. A lot of dialectical work probably, facilitating that. But how do we address that? And I think you spoke so well about, Judith Lewis in her amazing book on trauma and recovery says it's about creating the safe space for people to tell their stories, and then maybe with that Socratic questioning about is there a different way to remember this, or to rewrite this in which you're not the bad guy, or there's something wrong with you.
Well, I mean, and then good old principles like kindness and forgiveness, and I mean, I think that the pressure of the volume in many of our systems, creates sort of an assembly line approach to therapy where it becomes very technical, right? It becomes very technical. And I think that, as a good therapist, and the hardest job, my job was never hard in the military. The hardest job is the people sitting 3 feet across from people suffering all day, every day, right? That's the hard job. And to sit there and bear witness to people bearing their souls, right? Telling you things that they wouldn't tell their spouse, wouldn't tell anybody. And I mean, that's really what Jonathan Shea was talking about when he started talking about moral injury, when he was first sitting there in the Boston VA, about how these people felt about themselves and the things that they did. And I think that's the key. So I think, I mean, again, that the fear-based approach to PTSD, and that should be the first approach, evidence-based, do it. But if you've done that, if you've done the EMDR, you've done that, you check in on people. And I think we always talk about guilt and shame, but we forget anger, right? We forget the anger, the
Right.
institutional betrayal, and it's, I think that's important as well, especially with like a lot of the workers with COVID. We found a lot of that. The people that worked in long-term care, how supported they felt by whether it's government, whether it's their own leadership. But I think, bearing witness, listening, listening to them, and really being able to sort of, again, it's not my job. I'm not their priest. I'm not going to forgive them for it, but I just ultimately they need to sort of in some way reconcile this, right? And that's where, whether it's acceptance and commitment therapy, whether it's, adaptive disclosure, there's all kinds of approaches. But I think it really comes out, ultimately it comes down to forgiveness, understanding. Sometimes you can help people to understand that it may have been an outcome, may have been a bad outcome. But given everything you knew, you did the right thing, right? Even if it's something like that, which for a lot of the military folks, they need to just hear that. But sometimes you've actually transgressed your own moral, right? And this is where we have to kind of look at that, right? So I think it's really, really important. But I really think that we shouldn't forget the anger part, right? We shouldn't forget that.
Yeah. And, I think you mentioned the healthcare industry, and I think when we look at the first responder world, that is very true as well. And, anger is interesting because we've seen, these kind of ambushed attacks and killings even of, first responders by people in society, where you've got this complicated aspect to your day-to-day job, being on the streets, you're trying to do what you're doing. And you gave an amazing presentation on that actually at the first responder conference in Ontario, that their lives have changed. People have got their cell phones out, they're screaming to defund police and so on. And then somebody kind of being exposed to all of that goes, I'm going to take matters into my own hand and get them to come out on a 911 call and ambush them. And how do, and so there is anger. There's anger at society for kind of, taking this extreme notion. There's anger at my institution for not having my back when I get sent to the call of duty.
No, I mean, and these are extremely difficult times for things like that. And I mean, the pressure of social media, everybody's got a camera. I think it's kind of interesting in that way. But I think, like the, the idea, for example, the long-term care facility. I'm just going to give you a quick example of one of the first long COVID patients I saw, who was like symptomatic like a year after the COVID. But it was interesting talking to her about working in the long-term care home and early on days, right? They were given one mask that was supposed to last them the whole week, right? And it would get wet, they'd breathe on it, this kind of thing. And it was awful to try to get a second mask. We legitimately had a shortage at that time. But then they had the N95 masks that were sitting at the front foyer that were given to VIPs and politicians and people visiting, right? So somebody would come in, which could have been someone like me back in my day. Somebody would come in for a visit. They would give them like the beautiful N95 mask that they would wear for maybe 20 minutes. They would go nowhere near. They would go nowhere near the patients. They would go nowhere near the thing. But they had this mask that they would throw away afterwards, right? And so that memory and that thing was so vivid because it told her of how much value the company had in her. And of course, she got COVID, and she's in her head, if I had a proper mask, I wouldn't have had COVID, right? So I think that's a really important thing to think about. And I think the police thing, like for me, as a very much a population based, each person makes their own perception. It makes me think about social support, right? Social support after trauma, social support, perceived or real, actually makes a difference in your PTSD, the PTSD rate, right? So young lady goes out, she's raped, she comes home, and the parents that say, here's a blanket, here's a blanket, you're safe now, honey, we'll take care of you, this kind of idea, versus, what the hell do you expect going out dressed like that, right? So those two different kinds of things actually makes a difference in PTSD rates, right? So social support afterwards. So I think when you
Mhm.
look at sort of the Vietnam vets coming back as baby killers, as this and this, and the World War II vets coming back to these massive parades, I think those are important things to consider, and I think it does make it hard, and I think that I from an operational perspective, militaries and police, are constantly second guessing themselves,
Sure.
right? They're constantly second guessing themselves, and somebody's watching over their shoulder, and that could endanger themselves and endanger
Yeah.
some of the people that they're helping. But
Yeah.
it is definitely an aspect.
Yeah. I mean, and it's almost like who wouldn't, right? If you had
Yeah,
a kind of a lens on you all day long, ready to
yeah,
pass judgment on
yeah,
each decision that you make.
yeah,
Yeah.
yeah. And
Um,
and of
uh,
course there's people that do wrong, right? I mean, and they
mm,
should be, you
mm,
know,
mm.
that should be captured and people should be investigated, all of that stuff. So
Of
I mean, I think
course.
there
Yeah.
is that piece, but
Yeah.
it's
Yeah.
it's when it's when the entire society turns against you that it's difficult to be a soldier or first responder, anybody in uniform.
Yeah, 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 which is the difficulty with social media and kind of, how
Yeah,
do we get true education, not
yeah,
psychoeducation, just
yeah,
education,
yeah, yeah.
out there.
In Ottawa,
Mm,
there was a school board decided for a little while. I think they reversed it
mm,
that police shouldn't visit the classes to give them a talk or to do parent teacher stuff and all this
mm,
stuff, because some of the people might be triggered by police coming in, right? And the police were quite offended by that and saying, okay, but like, shouldn't we try to teach the kids that maybe in your own country the police weren't good, but here they are, and this kind of thing, right? So
sure,
so
sure.
I think it's really important. And I remember, for myself, I mean, I was go to my kids' schools for Remembrance Day and things like that, but I remember there was one time, we were doing a group thing in Halifax, and one of the patients was anxious about me because of my brown skin, and I looked like, kind of thing. And so I said, hey, you know what? Let's see how it goes, and we'll treat it as sort of maybe a corrective emotional response, and create some dissonance in the person, that not all brown people are bad kind of idea. And we did it, by the Wednesday, there was a week-long group. By the Wednesday, Thursday, we were chatting in the coffee breaks and all this. So I think it's really important to have this kind of opportunity, because we can slowly change people's perception of these organizations, and they're not
Mm-hmm,
all not all police are Nazis kind of idea, if we can kind of create
mm-hmm,
that.
mm-hmm, mm-hmm. Yeah, and I mean it's internally there's an audience that needs to hear the message that they are cared for and protected,
Yeah,
given these societal influences. And it is true, isn't it, Rakesh, that it's a changing world. It always occurs to me when it comes to Remembrance Day. I was taking the subway downtown, and I noticed how few people were wearing poppies, right?
yeah,
And so and it's because it becomes complicated, this idea when we see what is going on in
yeah,
Israel and Gaza, and it's like
yeah,
I'm not okay with all the innocent
yeah,
bystanders and victims, and therefore I don't believe in war, and therefore, as you say, I'm not going to look upon soldiers with welcome wreaths of thank you for your service, but as I'm not sure I believe in what you do. And then there's the idea that somebody protects our freedoms and keeps us
well,
safe, and sort of remembering why we have
yeah,
people that are prepared to
yeah, yeah,
elect to do
yeah,
these roles
yeah,
in society, so we can kind of waltz around,
yeah,
living
yeah. I,
this
I, I,
life
I,
that we
I,
do.
I think indeed it's complicated. I'll tell you a
Mm,
couple of things. I mean, I had the honor, actually, on behalf of the Royal College, of laying the wreath in Ottawa about 10 years ago. And I remember, my friend from the Netherlands flew in. It was a big event for us. But I think, when I speak to classrooms and I go to schools, which is to me even more thrilling on that day, is I try to talk about, we're not celebrating anything, right? Remembrance isn't celebration, right? Remembrance is about honoring people, honoring sacrifice, this kind of idea, right? So I think that's
mhm,
the important thing. So we don't celebrate war, right? We don't, like, no soldier wants war, and war is a failure everything. Everything else has failed up to that
Mm-hmm.
point, right?
Mm-hmm.
And so remembrance is a lot different than celebrating. We don't celebrate, the end of World War One. We commemorate. But I think the other thing to think about is, and I think my daughter put it best. She goes, "Dad, aren't there two good guys and two bad guys? Because to them we're the bad guys, to them we're the good." And so, and I think, I think we've got like extremes with things like Hamas maybe and things like that. But ultimately, most of the time, most people that go to war are young men mostly, and now women the last 100 years, and they go. And they go and they fight, right? And they're not necessarily the leaders. They're not this. So I think we have to I think we have to kind of think about that. So on November 11th at 11 o'clock, and I'm always out of the country. I was in LA, and people point at the poppy, and you get to tell them story about McRae and all this kind of stuff, right? And they really like it. So I think we do have to think about that. Like, we're not celebrating, we're remembering. And by wearing this, it doesn't mean I'm pro-war. So that'll be
Sure.
the
And I think a lot of that work is happening, I would say, being taken to the mainstream with people like Brene Brown or Kristen Neff and all her research on self-compassion, which of course talks to that moral injury piece, about how I'm talking to myself, the mindfulness work with kindness and common humanity. But it is what that self-compassion work is about her follow-up book, actually, with all the research, is fierce self-compassion. And we see that even in kind of Buddhist principles, is that it's okay to get very fierce when you are defending your boundaries. And Brene Brown's work on compassion is to say, isn't it interesting that those highest in compassion are those that also have boundaries of steel? And isn't that what our boundaries or our borders are, the things that need to be defended from being transgressed? And so yes, it's a complicated
There's a
arena for
piece of
sure.
that, but I think the compassion and the self-compassion is something that many of my patients that have been victims to many things. But I know we're interested in, so we're close to end of time, but I think one of the things that I'm sure many of the people on the call have done is when you listen to, for example, a woman in her 40s or 50s that was a victim of child sexual abuse, right? And she is so hard on her young self, right? Talk about this, the compassion. She's so hard on her young self that, time and time again, I say, imagine if it was the 7-year-old kid from across the street that came to you and told you what had just happened, right? But then they say, of course, I'd say, honey, you're safe now. It's not your fault, blah, blah, blah. But they can't show themselves that same kindness, right? So I really think it's important, and I think we use terms that are kind of maybe not hard clinical, but kindness, compassion, all of those things, and that starts with yourself, right? And so sometimes the boundary point is, boundaries can be so rigid that you don't allow yourself, right? You don't allow time for yourself, and I think that's the important piece, right? So but
Absolutely. And as I remember years ago, you coming to talk with us at EHA in Canada about moral injury. Is it a thing? Is it a thing? And now you're finally, yes, it's a thing.
It's a thing.
Is it a subset of PTSD? Is it, but the areas of treatment being different. And also, I think what you've peppered throughout this, discussion is this idea of, medications treat symptoms, but, we need to do exercise, nutrition. There are other things that can also help with inflammation, believe it or not, like the foods we eat and so on. But how do we instill in others this idea of self-agency and self-healing? Because isn't that the most powerful tool of all?
Yeah. I mean, Colin McKay, who our former Surgeon General, he and I were on a long drive once somewhere, and he said to me, Rakesh, half of the stuff we see, the heart disease and physical injuries, mental illnesses would go away if people slept better, ate better, and exercised more. But it's how do you get people to do that, right? And so I think there is a piece of that. And I think the problem with that kind of approach is it's not the magic bullet, right? And again, back to the days, our world of McDonald's and social media, people want instant. And I think the long haul of sort of, I mean, yes, there's treatments and there's an illness and all of this stuff, but ultimately it's this major change in your lifestyle that has to happen. And that's what recovery really looks like, right?
For sure.
And
Yeah.
recovery, your new normal could actually be better than your previous person.
Right.
And spouses tell me that. Like he's a better person now than he was even before he deployed, if we do things right.
This idea of post-traumatic growth, right?
Yeah, exactly.
And of course, people had talked about substances because, like, aren't we looking for the quick fix, right? Like liquor is quicker, as a solution to how I'm feeling. And I loved how you brought in this element of family and the systems we need to look at that help with that, and those kind of community supports. So community supports,
100%.
peer supports, are so valuable in that business of making amends, right? Which to amend is to change. Forgiveness and amends are talked about in those adaptive disclosure therapies for moral injury. And that's some of the good old-fashioned work that has been happening in the 12-step paradigm and so on for a long time. So finding supports within families, within communities, within the self. A great place to look as well.
And we're almost out of time, but but the one thing is all of that stuff has in common is listen to your patient. Remember, therapy isn't something you do to them; it's something you do together, right? And so this is where the key is. You need to listen, and they will help you. They will guide you towards what will be helpful, I think. So I think that's where and that's the new therapies are kind of, less sort of manualized, guided, but they're more let's communicate, let's have a back and forth, and I think that'll be the key.
All right. Well, as always, thank you so much for your wisdom and the ongoing work that you're doing in this field. To continue to look for, my goodness, medications that address the amygdala for PTSD or whatever else may be on the table.
It's going to be so cool when we get all this stuff. It's the journey. The journey is wonderful, and we're just on our way. So it'll be so interesting to see where we go. And we'll have precision medicine at one point. We'll figure out what works for who and all this stuff. So it's very exciting.
Yeah. And I think, as you say, it's like we are looking at ways that we can improve efficacy because while we have some ideas on how to make it better, there's still a long way to go.
100%.
And so, again, collaborating to that end is always wonderful. And I don't know if I need Sue-Ann to bow us out or whether I can just do the thank you at this point. And also to all our guests who attended and so many staying with us right through to the end.
I've been tracking the discussion. It's been fascinating. I'm going to read them all afterwards. They went to spirituality, complex PTSD, addiction, harm reduction. So I was listening, folks.
Yeah. And those are all such great questions, right? What vulnerabilities do we begin with? And so on and so on. We could talk about this all day, as we often do.
To be continued. So
yes, absolutely. So thank you so much, everybody, for your time and for being here, and most of all to you, Colonel Retired Jet Li, for today's session.
Always a pleasure. Okay. Bye-bye, everybody.
Bye-bye.